Dr. Ahizechukwu Eke, who's an associate professor, Division of Maternal Fetal Medicine at Johns Hopkins University School of Medicine. Dr. Eke, thank you so much for joining us today, and I'm looking forward to your presentation here. So let me pass over to you. Thank you.
Thank you, Neil. Thanks for the invite to speak. And like you said, this is a very good segue to speaking about Glecaprevir, Pibrentasvir in pregnancy for people with hepatitis C. And just like Dr. Chappell said, I totally agree with all you said with respect to drug studies in pregnancy, which I have been doing. And I know most of the people here, both at the FDA level and the NIH, and we've all been working together to try to get a solution to how to move things forward. Next slide, please. So based on a couple of studies, some of them which you presented earlier on and so many others that have been presented earlier, we in ACOG, the American College of OBGYN, decided to move ahead with universal screening for persons with Hep C. And we thought so because even though we don't have an approved medication right now to treat them in pregnancy, we felt that there are multiple reasons to proceed with screening of pregnant persons with Hep C. Next slide, please. And the reasons mainly which the speakers previously has talked about, if we identify them during pregnancy, while we don't have any approved therapy at the moment, we can actually identify them, connect them with the GI docs who would commence treatment immediately postpartum. And we've seen that more and more patients are being identified during pregnancy, even though we know that there are a lot of advantages to treat them during pregnancy. But for now, screening during pregnancy and then treating them postpartum is where we are. We're very hopeful that in the next couple of years, things are going to move forward with respect to treating during pregnancy. Next slide, please. So this is just a review that we did a couple of months ago, which was published, just kind of the landscape of where we are with things and current ongoing studies, which some of them have been discussed here as well, and then how to move forward with them. Next slide, please. And so in the next few minutes, I will just discuss what we are doing with this study. So the IMPACT is the International Maternal Pediatric Adolescent AIDS Clinical Trials Network, which I know some of you know. A couple of months ago, we decided to proceed with the PK and safety of Glecaprevir, Pibrentasvir in pregnant people with Hep C. Just like Dr. Chappell said earlier, this medication is one of the first-line medications used to treat patients who are treatment naive for Hep C during pregnancy. It's very effective and has been shown to be safe based on data from several randomized trials, which includes the Endurance, Expedition, and the Surveyor trials. And more so, this drug is also very effective for the genotypes types 1 through 6. So it's pan-genotypic in terms of its efficacy. And so we felt that we could look into this to proceed with how to study this drug in pregnancy. We also looked at the DART studies, which are the earlier studies in non-pregnant persons in animals to see what the data was. And part of the things I do is I'm also board certified in pharmacology, so I also do those early PK work. And we realized that even with increasing the NOEL, which is you increase the doses of these drugs 5 to 10 times the dose, we did not see any signal, even in non-pregnant persons. And so we felt that it was safe to proceed, and we got approval a few months ago to proceed with this study. Next slide. And so this is just where we are. We are in the very early stages of this study. It's currently funded by the NIH. We are currently meeting every week to finish the writing phase of the protocol, which we hope to finish in the next couple of weeks. I'm hopeful that by April or latest by May, we will complete the protocol writing phase. Our aim is to recruit 30 patients who are evaluable. So we'll probably go higher to get patients who are PK evaluable, which is our main primary outcome. Then we're also looking at efficacy as well as safety. A couple of differences between this PK study and the previous PK studies of these DAAs in pregnancy. We are going to look at both HIV-infected co-infection as well as HCV as well, because we know that a good percentage of patients who are HCV infected are also HIV infected. We are aware of the drug-drug interactions, and we're going to exclude any patient who has any drug that is an antiretroviral that might co-interact with a direct agent. And so our goal is to recruit 2/3 of them being HCV positive, and then 1/3 of them having a co-infection. The beauty of this therapy as well is that rather than 12 weeks, it will be for 8 weeks as treatment similar to the treatment in non-pregnant persons, and then we will be able to look at both the PK and safety. The other difference as well is we are going to start at an earlier gestational age. I have experience with doing these earlier drug trials. We would not wait for, we are going to likely recruit from 14 weeks upwards for a number of reasons. We felt it was safe, and having done that in a couple of HIV studies, we also felt we could proceed with it in this study. Hopefully, we're going to start recruitment by the early fall, which is towards September, October this year. I don't have much to say now in terms of inclusion, exclusion. We're still working all those details out. But hopefully at some other time when I have more, I would be happy to present that. And I'm happy to answer any questions later on. Thank you. And